Hello, everyone, and welcome to another episode of Fertility Docs Uncensored. I am Dr. Carrie Bedient from the Fertility Center of Las Vegas, joined by my two marvelous, magnificent partners, Dr. Susan Hudson from Texas Fertility Center
Hello, everyone.
and Dr. Abby Eblen from Nashville Fertility Center.
Hey, everybody.
And today we are joined by Dr. Barrett Cowan, who is a reproductive urologist. He is the CMO, Chief Medical Officer, and co-founder of Posterity Health. And so and an all-around nice guy.
Yes.
And so we're going to be talking about all his stuff later, but Barrett, we are very happy to have you with us. And as we were talking right before we started, we have a zillion and a half topics. So hopefully we get you back too, because we could fill up probably several hours worth of conversation with you.
I'm feeling a male reproductive series.
Yeah, that'd be a great idea.
So
we're glad to be here. Thanks for inviting me, and really honored to be part of your podcast.
Well, we were just talking beforehand just about kind of hobbies and what everybody likes to do. And you said that you get a sporting advantage from living in Denver, right?
Well, Denver is at altitude, and the oxygen level is thinner, and the air is thinner. So in the sport of golf, for example, the ball actually travels further, which is potentially an advantage, although it doesn't necessarily go straighter at altitude. But that's why you'll see like a lot of endurance athletes, cyclists, runners train at altitude, right? Because it really coordinates their body, so they assimilate to that altitude, and their body becomes more efficient at carrying oxygen. They get more red blood cell mass, they transfer the oxygen more efficiently, and so on when they go back down to sea level.
So do you have a really high hematocrit then?
Yeah, I think the average American male hematocrit is like low to mid 40s. In Colorado, in Denver, it's 45 to 50.
Interesting.
Yeah.
So you have to translate that. So like if you have somebody with significant anemia or a low red blood cell count, that's a really bad thing if you're up that far in altitude.
Correct. Absolutely. And for people who have obviously other underlying lung disease, they don't typically do so well at altitude either, because they don't exchange oxygen as effectively as people who don't have lung disease. But yes.
So you think that the golf ball advertising companies do all of their trials in Denver so that they can say that their golf balls go however much longer and be honest about it? Like that would be a fantastic advertising gimmick.
Well, actually, so there is a professional golf tournament here in Colorado this summer, and it's interesting because the players who are obviously the best players in the world actually struggle because their distances actually vary quite a bit. There's anywhere from 10 to 15% less less club that they require for each shot because of the altitude.
It actually
they actually struggle. Yeah.
I was thinking that was actually when most athletes are training at higher altitudes, they gain an advantage because of their learning how to survive in that kind of decreased capacity. Whereas with golf, if you take yourself out of that or go into it, like having to compensate like that, it's like my swing normally does this and being like, oh crap, what happened to the ball?
Yeah, I feel like I'm a pretty big hitter in Colorado, but when I go to sea level to California or some other place, I go, my ball's not going anywhere.
Oh, wow.
Is there an associated advantage to sperm? Like if you have someone who normally lives at altitude and they go down and all of a sudden they've got all this extra quote unquote oxygen around, does that make their sperm better and swim faster in the same way that any other athlete would do better at sea level?
That's actually kind of an interesting question. Are sperm better swimmers if they train at altitude, right?
Yeah.
Is the real question. I think probably not, because I think what happens is the sperm acclimate also to altitude versus sea level as well. I don't think anyone that's actually studied, what is a guy who lives at 5,000 or 6,000 feet altitude, what happens to their sperm count and motility if they go to sea level. So I don't think it's really been aggressively looked at. My guess is theoretically is probably not much of an advantage.
I feel like this is a med student project coming
Yes, for sure.
All right. So Susan, do you have sperm questions for us today,
I
especially
do have
because
sperm questions. I was so excited when I heard Barrett was going to come. I'm like, ooh, we can ask questions that we can take the heat off of us.
Yeah, for a change.
100%.
All right, here's our first one. My husband and I have been trying to conceive for about a year, no previous pregnancies, recently saw REI. I'm 32, good health, all the tests came back normal, blood work, HSG, ultrasound. Unfortunately, we learned that my husband, age 31, had normal sperm count and motility, but only 3% morphology. The only treatment offered was IUI. After doing some research, it appears that there are some lifestyle changes that could help morphology. For example, he uses Zen nicotine pouches that he thought were a healthier option to tobacco products. Could this be causing low morphology? Is it worth delaying the IUI procedure for a period of time until he makes some changes? Is it possible that we won't need IUI? Thank you so much.
Great. That's actually a relatively common question, right? What does the morphology mean? And there's actually mixed data on that. And part of the issue is because, there's some people who have really poor morphology and can conceive naturally without any problems.
Yeah.
And yet there's people who have seemingly mild or moderate abnormalities in morphology and really struggle. And so I think morphology is an important assessment, but it's certainly not the gold standard when we're doing a seam analysis, but it certainly can provide some useful information. But in answer to the question, I think there's no doubt that lifestyle and behavioral impacts of sperm quality and sperm function very aggressively. And so, for example, what I tell my patients is like, if you want to be a father, listen to your mother. And my patients say, "What, Barrett, what are you talking about?" It says, like,
I love that.
Yeah, because most moms, when you're growing up, say, "Hey, don't smoke, right? Don't use drugs. Don't drink too much alcohol, eat right, don't get overweight," because all those factors actually can significantly impact sperm production. And obviously in this era, many states, marijuana is legal, and not just legal, but socially acceptable. And we see some significant changes in the sperm's ability to cause fertilization with marijuana use as well. And so there's a lot of lifestyle and behavioral things that people really can and should do to really improve their fertility status, and that'll help them, facilitate the whole conception process.
So if somebody were to make some lifestyle change, like stopping nicotine, losing weight, stopping alcohol, not smoking pot, anything like that, like how long should they be doing those things before they expect to see a difference? And then how long should they try after that if everything else is normal?
Right, great question. Because when I think of sperm production, I think of it as a long assembly line process.
I'm going to add the caveat, and she's less than 35 years of age.
Right, great. And which is an important thing. And obviously fertility status of the female partner is really critical. Like when I see a male patient, I always ask them, all right, let's get some information on your partner. Because I want to know her age, her reproductive history, her ovarian reserve. All these factors are really important, because if she has a significant issue, no matter how good his sperm is, they may not be able to conceive, right? So this is really a couple's issue, really not a male issue or female issue in my mind. And that's why I really like to have both partners involved in these conversations. And one of the ways we do that is with telehealth, which has really been well accepted by my patients. It's not only more convenient and it's not only more accessible and efficient, but there's a lot less stigma associated with the guys doing this from the comfort and the privacy of their own home.
Yeah.
And more frequently, their female partner will be part of this conversation as well. So that's the first thing. In terms of the time frame, the generation of sperm, it takes on average 72 plus days. So I think of it as a 2.5 to 3 month process. So when we make any intervention, whether it's a lifestyle behavioral change, new medication, any kind of removing a medication that may be deleterious to sperm production, we say, okay, let's hear the changes we're making, come back in 3 months with repeat semen analysis. So it takes really a 3 month process is the way they should think about it.
And if someone starts and then dead on 3 months later, they check it, can they really expect to see a huge change from that time? Or functionally, is it actually more along the lines of 6 months or longer to get it? Or is it really reasonable to say, okay, in 3 months, we should see an appreciable change?
Yeah, I think it really honestly depends on the severity of the intervention that we're doing. Like, so people obviously who are been, smoking pot daily since age 15, right? And now they're 31, 32. And they say, okay, hey, I've stopped for the last 3 months. I don't necessarily think we're going to see a dramatic improvement over that period of time, right? So part of it related to the cumulative exposure to whatever things, right? I think also if someone weighs 300 pounds and their optimal weight is really 190 or 180 pounds, and they say, oh, Barrett, I've lost 50 pounds. I said, that's great. 50 pounds is a really good start, but that's still above kind of where optimal weight for you.
And when you tell our male listeners, why is weight important? Because women think about it a lot, but men never, because, a lot of times if they're too heavy or they're too lean, they don't have periods. Well, men don't really seem to get that weight's a big issue for them too.
Yeah, weight is a huge issue for a couple reasons. One is that, remember, when males are overweight, we tend to carry our weight really low, right? Mm-hmm. And so you may be seeing somebody on on a Zoom camera, and they go, hey, you don't look that big. With the shoulders up, you look fine, right? Because we carry our weight when we're heavy down low. And remember, the sperm are produced in the testicles, and the testicles are the scrotum. Remember, the temperature of the scrotum is a couple degrees cooler than body temperature by design, because the sperm need to be at a couple degrees cooler to be optimally developed. And so that's why they're in the scrotum, not in the pelvis like the female ovaries. So anything you do to elevate scrotal temperature may have an adverse effect on sperm production. And that's why we say, hey, like hot tub, steam room, sauna, avoid, right? So when you're overweight, you're not applying exogenous heat to the scrotum like you are in a hot tub or in a steam room.
There's a little more insulation there.
You're preventing the normal dissipation of body heat, right? So that's part of it. Secondly, when people are overweight, there can be significant hormonal balances between the ratio between testosterone and estrogens in the male. And we all males have a little bit of estrogen in us. It keeps us sane, right? And but that ratio between testosterone and estradiol, which is the main form of estrogen in males, is really important to be optimally making sperm. So when you have excess, fatty tissue, there's a higher conversion of testosterone to estradiol. And so that's certainly the other main factor. And then the final thing is that when people are overweight, there seems to be a higher levels of overall general inflammation within the body, which also negatively infects sperms.
Interesting.
All right.
Oh, I was going to ask another question about going back to weight. Is how close to ideal body weight do you need to get to see those positive impacts? Like if we go by BMI, which is of course imperfect, but kind of the best we have, how is there a range where beyond this you're really in trouble and under this you're only in moderate trouble?
So the part of the problem is like, just like when people are overweight, there's some people who weigh 400 pounds who have no problems conceiving, right? There's people who smoke, I tell people, hey, I really want you to knock off the marijuana piece. But my friend Joe's a total pothead, and he has 5 kids and they conceived in a hot tub, for God's sake. So there's, everybody has different levels of sensitivity. So I don't really a strict rule, but I'd say getting as close to the ideal body weight is really what we're targeting with a BMI, obviously in the low 30s or lower. Right?
I do have to say, I love hearing that you hear the same things from the guys that we hear from the ladies. Because it's, we always wonder what's happening on the other side. I think the guys probably open up a little bit more to their urologist, and the ladies open up more to their reproductive endocrinologist. But the thought processes seem to be pretty cohesive.
Very, very much in parallel. And one of the interesting things is, I have a lot of guys who know that they should be cutting back on their alcohol, right? Consumption. They know they should be losing significant amount of weight. They know they shouldn't be smoking because it can negatively impact their health. And they've been told that for years by teachers, parents, even family practice physicians. But when they're not seeing really the impact of that, when they come see me and I say, look, your lifestyle stuff is actually having a direct effect on your function right now, right? And suddenly, look, I'm not going to tell you that all my patients lose the amount of weight that I want them to, because they don't.
But it's a good motivator, though.
They listen much more to me than they do their primary care physician, because they're actually seeing the negative impact that their weight is actually having on their function. function right now.
One thing I often say is, all the bad reasons for the reasons why we want you to quit blank, blank, and blank. I'm like, this is a good reason to quit.
Right.
Blank,
Yeah.
blank.
Right. And my goal is, look, I'm not trying to nag you. I'm just trying to give you more motivation. This is, this is something that's going to take time and work and energy on your part and really commitment, but it's worth it. And ultimately it'll lead to better health. You want to be healthy and you want to be around for your offspring. And
Yeah, that's right.
Absolutely. Well, let's do one more question. Okay. We got to take advantage of him while he's here. My husband and I got pregnant after only a couple of months of trying, a little less than 3 years ago. Unfortunately, it was an ectopic pregnancy, resulting in losing a fallopian tube and, of course, the embryo. We have now been trying for almost a year and still haven't been able to conceive. We own a restaurant. He works the grill, which sits about hip level. I am wondering if this could be the cause for low sperm motility. At the time of our previous pregnancy, we had owned the restaurant for less than a year.
Oh, good question.
Great question. And I actually do see people who are, working hard in a restaurant, who are on the grill and around really significant heat source, right? That can negatively impact sperm production. So the answer is, it's certainly in the realm of possibility. We would obviously want to look at other possibilities as well. So I'm not going to hit all the blame on the grill, but that's a major risk factor. And so when we see a patient who has abnormalities in their semen analysis and difficulty conceiving, we do a very thorough history about heat exposure, other medical issues, right? Other lifestyle behavioral aspects, hormonal labs. So it's part of the evaluation. Is it reasonable for this individual to say, okay, I'm not going to go on the grill, I'm going to hire somebody else? Maybe yes, maybe no. If they own the restaurant, it's going to be a little bit of a challenge, certainly. But we want to try to minimize those risk factors. But it is a risk factor, but there may be others. And that's why getting a thorough evaluation is so important.
One thing that I think is really important is when we see patients in our clinic, we always, on their initial information, we ask what profession different people are. And a lot of people leave that off because I think they think, well, it doesn't matter what I do. How could this possibly affect my fertility? But especially in male reproductive health, I think it has a huge impact. If you're sitting there working on a grill, our firefighters. I recently had a patient who tests radiation exposure in like oil field something or others. It's
I had an embalmer one time who had lots of sperm, but they were all dead.
Yes.
Formaldehyde's the worst.
He didn't wear his gloves. Yeah.
My
Apparently you have to have really specific gloves.
guy, completely normal semen analysis, abnormal sperm QT. And I'm like, and he was young. He was like in his mid-20s with no other exposures. And I'm like, realistically, I think this is what your job, this is probably due to your job. I can't ask you to stop doing your job. So let's see what we can do to, maximize things from this point. But especially from the male side, I think including what your profession is for your physician is really important.
Yeah.
How much of an impact so these are all things where there's direct heat at, waist level. What about where it's just kind of ambient temperature? I mean, I live in the middle of Las Vegas. I have a lot of guys who do construction, who do electrical, gas, plumbing, things like that, HVAC, where
anything outdoors.
They're outdoors a lot, and that includes in the summer. And so they're always, wearing pants, rather than shorts or something more drafty. And how much does just that make a difference? Because if you figure the testicles are able to descend, at least the normal amount,
right,
to not be up in the body, is that is that outside heat making a difference?
When you think about it, so like when we tell people avoid a hot tub, so what's the temperature of a hot tub? Typically like 102 to 105 degrees, right?
Drop in the bucket in Texas, or
that's a day in Vegas and a day in Houston.
Totally agree with that, and that's my point. And so it's definitely a risk factor for these people who are doing physical work outside in the heat. There's no doubt about it. Absolutely a risk factor. And it's hard to minimize it. People need to make a living, right? And people aren't going to move from Phoenix or Las Vegas or Houston, or in Texas when it's during the summer, because it's just not realistic to expect them to do it. So we have to really accommodate things otherwise. What else can we do to help them? What other assisted techniques can we use to kind of facilitate conception for them?
I have a brilliant idea for a product. We should get self-cooling underwear for guys.
Hey, there you go.
It's actually been developed in the past. And
Has
they
it?
have looked at these cooling underwear, and they looked at it, and they said it definitely decreases testicular and scrotal temperatures. Didn't seem to have a huge impact on sperm counts or quality in the past, but you can actually find them sometimes out there. Yeah.
Huh.
Yeah.
All
So
right.
great idea, Carrie, but
Somebody's already thought of it. Sorry, Carrie.
Yep.
All right. Guess I won't get rich off of that.
Yeah.
Too. Maybe something else. All right. So one of the things that we really wanted to talk about so that our listeners can hear is what you as a reproductive urologist do. And let's start probably with the simplest part of this answer, which is what kind of training do you do to get to where you are today?
Right. So, reproductive urologist is really the kind of corollary to, on the male side, to a reproductive endocrinologist, right? We're male fertility specialists. And just the way you guys have gone through medical school and OBGYN training, you did extra training in female fertility. And that's what a reproductive urologist has done as well. So they've done, not after medical school, completed a residency in urology, which is typically 5 to 6 years, and additional training in male fertility for 1 to 3 years as well, beyond that residency. And then obviously, the group of reproductive urologists is relatively small in the country. There's probably only 200 of us in the country, which is a problem, right? Because there's a lot of people who are struggling with fertility issues, right? And I think many people kind of assume, oh, we're having a hard time conceiving. It's got to be it's a female issue. And it turns out that at least half the time, there's at least some contribution on the male side. So our job is really to help couples conceive by working on the males, to evaluate them and see what we can do to optimize their fertility, really facilitate the whole process of conception. So we work very closely with reproductive endocrinologists, which is because, again, this is a couples issue. It's not a male issue. It's not a female issue. Our goal is to bring the couples together, not separate them and not pull them apart. Let's work on these issues together in parallel, make it really and so they don't really struggle through this process.
It's a team sport.
It's a team sport. It takes 2 to tango, right? I mean, it just does, right?
If somebody makes an appointment in your office, what would a guy expect when he's going to see you for care?
Yeah, we give them the option of either seeing us initially through telehealth or in person. And again, I think telehealth has been really well accepted. It's more efficient, and it's also a little bit less threatening for many individuals. At some point, the patients will need a physical exam because we want to make sure that all the parts are where they're supposed to be and no missing parts and no extra parts. But we do a very thorough evaluation, and our initial visits range from 30 to 60 minutes. And we have them fill out a questionnaire in advance, which is a very efficient way of our getting some information. And we go through the questionnaire and ask them a lot of other questions about, their lifestyle, behavioral things, other medical issues, about their sexual history, family history. Are they taking any other medications, and so on?
Can you comment a little bit about other medical conditions in men that can have an impact on sperm function?
Yes, absolutely. It's really interesting. Even like minor things can transiently impact sperm numbers and quality. For example, getting sick, right? If you have a fever, whether it's the flu, COVID, a bad sinus infection, or a bad injury where there's a significant inflammatory environment in the body, that can negatively impact sperm production for a generation, which again is about a 3-month process. So while COVID is not really different than other ones, but because of how common COVID is now, we see impact for people who have COVID, who get sick. And you don't have to be like hospital sick, but if you have really flu-like symptoms with COVID, with fever, that can transiently impact sperm production. There are other underlying issues, other health issues that can certainly impact the whole reproductive process, whether it's underlying neurologic problems, diabetes, so on. There are some blood pressure medications that can negatively impact sperm function, where they're called beta blockers or calcium channel blockers that can have a negative effect on sperm production. And many of the patients who are on antidepressants, such as SSRIs, can have a negative impact on sperm function as well. Now, if someone is on a medication that we think is a risk factor, I never tell them to stop the medication, right? I say, hey, let's talk with your physician who prescribed the medication, say, are there alternatives that would take care of your underlying issue and yet not have a negative impact on sperm function or production?
So how do you approach in a different way treating patients than perhaps a regular urologist? So for example, I had a patient who I just referred to you, so he's on his way to see you actually, who has seen several regular urologists. He said at least 3 or 4. He has significant erectile dysfunction, and at least now at the beginning of their testing stage, that's the only thing on their history that I can identify. Everything else is pretty squeaky clean for both partners, but he's tried Viagra, he's not now on Cialis, and he just is really struggling. And so how does a reproductive urologist approach this differently than a general urologist?
Yeah, great question. You know, the average urologist, quite honestly, doesn't have as so much the expertise or the interest in reproductive care. They haven't done the additional training or maintained the continued medical education and the continued learning and the meetings that we keep going through over and over and learning and reading the articles that are, there's so much information out there that's hard to keep, up on all aspects of medicine in general, yet in urology, right? And so our focus is so much on the reproductive care that we're really on top of what's happening and the latest changes and the newest studies that come out. And our focus and quite frankly, our interest is in this area as well, right? So when we're really passionate about helping these couples achieve their goal. And so we spend time with them, we support them in a variety of different ways. And sometimes we have different ways of thinking about these issues that the average urologist may not. And our evaluations are probably more thorough because it's more focused on dysfunction.
One thing you just mentioned is time. I know a big difference between when our patients go see their local OB-GYN and they have maybe a 10-15 minute appointment versus when they come to see us and that may be a 30 or 45-minute appointment. Is that some of the things that are involved, just that you have the time to sit there and focus on these very personal issues?
This is a really sensitive topic for many people. It can be emotionally jarring. Many males come in with this thing like this is questioning their virility or their masculinity, and it's not. This is a medical issue, and we want to support them through this whole process, right? It's really critical that we do that. And so being able to give them the time and the emotional support as well as the medical support is really, really important, because we don't want them walking out of this office saying that, this guy has just kind of dragged me down because he's told me all these wrong things that I'm doing wrong. We say, hey, we want to encourage people to be successful in their endeavors. And so being able to support them and keeping it in a positive aspect is really critical.
You also mentioned a physical exam. And I have to say, I'm pretty sure that's the part that the guys really are wanting to avoid.
Yeah, that
Can you give
is.
people insight as to what exactly you do and what are some things that you're looking for that could help us be more proactive in helping them achieve better sperm function?
Yep. And when we do a physical exam, there's general aspects of it. Like someone will come in, we'll look at their overall body habitus, what is their weight based on their body size and so on, Do they have any other developmental issues that appear? Do they have any breast swelling or tenderness suggestive of maybe an underlying hormone issue? They have any thyroid abnormalities? Thyroid function can certainly have a negative impact on sperm production if it's not functioning quite properly. So those are kind of general things. And then our focus is really on the genital region. We'll look at the penis to make sure that everything's kind of where it's supposed to be. There's no missing parts there, that the urethral opening is where it's supposed to be. There's no scarring along the way as well. We'll examine the testicles, make sure they're the right size, consistency. And then there's a lot of things that are attached to those testicles. There's not just like testicles in the scrotum. There's a gland called the epididymis attached to the testicles where the sperm actually mature. So we'll examine that to make sure it's the right size and consistency and not inflamed. It's also connected to a tube called the vas deferens, which is the main conduit that transports sperm from the scrotum where they're being produced up through the groin and down the pelvis and the prostate for ejaculation. So when like people have a vasectomy, they have a piece of the vas deferens removed and tied off, and that's for permanent sterilization. And then we look for things like, varicoceles, which are dilated veins or varicose veins going down to the testicles, which are also associated with a risk of having infertility as well on the male side. So those are kind of the main things we focus on.
One question a lot of guys always ask me is, well, if I had a varicocele, would I know it? And so what would you say to that?
I think the answer is maybe. Like there's some guys who come to see me and they say, I've had this like feeling like I have this bag of worms in my scrotum since I was a teenager. I think I have a varicocele.
Yeah.
Has anyone ever told you that? A doctor ever told you? No, but I think I have a varicocele. They tell me that. And sure enough, when they come in, I examine them, they have this like, truly, that's the kind of the bag of worms, these dilated veins above the testicle. And that's a larger varicocele that becomes more obvious. But there are certain maneuvers we do on physical exam to try to elicit the presence of a varicocele or not. So there's some people who have not a massive varicocele that may not know. And so that's part of our examination. And varicoceles can certainly cause other issues other than infertility. They can cause some discomfort, the kind of typically this chronic dull aching in the scrotum or in the testicle. They can cause some testicular atrophy where the testicle will be smaller on that side than it is on the contralateral side.
So kind of from our perspective, I see varicoceles as something that's a pendulum in the reproductive medical community. Where is the pendulum at this point when it comes to varicoceles, at least from the urology perspective?
Yeah, so that's a great question, because I think the thought on varicoceles and the relevance of them has shifted with time. And the part of the problem is varicoceles are common. About 15% of men have them. And not everybody who has a varicocele has any issues with them at all. In fact, I've done many more vasectomies over the years on guys who have 3 or 4 kids, and they come in for their vasectomy. I go, "Oh, you have a big old varicocele. Did you have any problems conceiving?" No. And because it doesn't impact everybody. But with that said, it's still probably the most common cause of correctable male fertility that we see. Statistically speaking, there's really good data that says if a person has a difficulty conceiving and has an abnormal semen analysis or an elevated DNA fragmentation test, and I don't know if you guys have been talking about DNA fragmentation at all on your podcast in the past, and I'm happy to go into that if you'd like. But it turns out that fixing the varicocele has about a 50% chance of improving one's fertility. And again, it takes, going back to that time frame office, it takes a minimum of 3 months to have that improvement. If we end up choosing.
Is that because it increases the numbers or the motility or the morphology or all the above?
It can improve each and every one of the above. Yeah, numbers, quality in terms of motility and morphology as well, and also DNA fragmentation.
Is it okay when somebody comes to see you if they have not had any testing done? Do they have to have all the testing done? Do they have to have a bare minimum of a semen analysis? Like if they come to you saying, I have X medical problem and I'm pretty sure I've got an issue. At what point do they see you? Do they have to see us first? Do they have to see their primary first? Like when's the right time for them to go?
I think that's a really great question. What I strongly believe in is, because to assess male fertility is such a quick, simple, and relatively inexpensive test to do. Like when women go to see their gynecologist, for example, for a preconception consult, right? Say, hey, we're thinking about starting a family. I'm ready to go off the pill or have my IUD pulled or whatever. Let's talk about that process, right? And I'm totally fine with guys going through that process with us. And we offer what we call a baseline assessment, where we do a semen analysis and a results call. And we actually have them even do the semen analysis at home. So they collect the sample at home, they ship it to a lab, and then we talk to them, and then we do a brief history. And it's really just a way of assessing, is there a male factor, yes or no? And so for people who are thinking about starting a family, getting evaluated really early on in this process, say, is this something I need to deal with, or can I just like not think about it? I think it's really important to get the guy evaluated early on in this process, because what I see so many times is, a couple will be trying to conceive for 6, 12, 24 months, and the guy's never even been evaluated. Meanwhile, the female has been going to her gynecologist, and she's been through all kinds of testing, and then finally gets referred to a reproductive endocrinologist. And then 24 months later is when the guy first does his semen analysis. And and it turns out there's nothing wrong with the female, and it's all on the male side in many of these situations. And so we say, hey, let's get the guy evaluated early on in this process. And we work with several very large OBGYN groups across the country, where we're saying, hey, let's make this part of your evaluation, is just to offer the couple a at-home semen analysis kit, and we'll take care of all the work for you, all the dirty work in terms of shipping them the kit, doing the results review, so you don't need to worry about it. And we're trying to make it, again, easy and remove the stigma of male fertility. We call that our baseline assessment.
I think that's so important. At least once every week or every 2 weeks, I have a new patient that it's like once female evaluation only at this point in time. And I'm just like, no.
Right. Which gets back to my earlier point where I said, everybody kind of assumes this is a female evaluation, or the guys are more reluctant to go through an evaluation, right? And that's why we're trying to make it easier for them, and say, look, just do this at home. You don't even have to come into the office. You don't have to go to a lab to collect a semen sample, which many people find very awkward to do as well. Let's make this as easy as possible and remove the stigma associated with this.
That's awesome. I am so glad that we were able to have you on today and making us not so subtle push of, hey, come back and talk to us more. Part of that is nice because it means that A, I get all the extra education, and B, I get to see you more, because this week I've gotten lucky where I saw you once before and once after, because we are very fortunate in Vegas that there's nobody in the entire state of Nevada who does what you do, and you guys come to us, and that allows us to give better care to everybody who lives here, which is phenomenal. And so I am very appreciative of your company as well, because it opens up access to care that otherwise doesn't exist. So
yeah, thanks. I mean, that's our goal. Was when we started it, I guess I told you, I'm very passionate about male fertility care, and our goal was to really change the paradigm to make male fertility care more accessible. We have 9 regions across the country. We have 2 doctors actually in Texas. We have 1 in Nashville. We have New York. We have 1 Atlanta, California. So we're really trying to say, hey, let's make it easy for people to get male fertility care. So yeah, thanks so much for having me on. This has really been a pleasure chatting with you, and I would love to be a return podcaster with you at any time.
Oh, we would love to have you.
Yeah.
all right. Well, thank you so much to you, Barrett. And this is Dr. Barrett Cowan from Posterity Health, male reproductive urologist. And to our listeners, thank you so much for listening. We are forever appreciative of that. Remember to subscribe and leave us a note or review in Apple Podcasts, iTunes, Spotify, all of those places, YouTube, Instagram, Facebook, all of that.
You can also visit us on fertility.suncensored.com to submit specific questions. All of our questions will be answered on our podcast anonymously for our Ask the Doc segment. Leave us an episode idea or other information. We'd love to hear from you.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon.
Bye.
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 Bye.